Are you over 60, managing your blood sugar, and assuming your bones are fine because you haven't broken anything yet? If so, I need you to hear this because the damage may already be happening, silently, right now, and the cause might be sitting in your medicine cabinet. It's not a hidden disease or something you missed, but your medication. As a physician who has spent years treating diabetic patients over 60, I've watched this happen more times than I can count. Today I'm going to walk you through 3 widely prescribed diabetes drugs, and for each one, exactly what it's doing to your skeleton, and one daily habit that can slow the damage. Because here's what most doctors never tell you. Studies suggest that roughly half of all adults over 60 with type 2 diabetes have weakened bones, and the majority have no idea their medication is part of the reason why. Most of my patients say the same thing when I bring this up. I thought the back pain was just getting older. I figured I'd earned a little stiffness. I heard something very similar from a 68-year-old retired teacher who came to see me after a minor fall fractured her wrist. She was doing everything right. Great A1C numbers, stayed active, never missed a dose. Her blood sugar was under control. Her bones were not. The very medication keeping her diabetes in check had been quietly weakening her skeleton for years. Today, I want to show you exactly what I showed her. Before I name the 3 medications, I want to make sure you understand what's actually happening inside your body, because once you see it, everything else will make sense. Most people think of bones as solid, still objects, like rocks, something that just sits there holding you up. But your bones are alive. Right now, as you watch this, your body is breaking down old bone tissue and building new bone tissue at the same time. This never stops. It happens every single day for your entire life. Think of your skeleton like a construction site that runs 24 hours a day, 7 days a week. On one side, you have a demolition crew. These are cells called osteoclasts, and their job is to come in right behind the demolition crew and build new, strong bone in its place. When both crews are working at the same pace, your bones stay strong and dense. The system works exactly the way it should. But here's where things go wrong for many people over 65 who are managing diabetes. Certain diabetes medications interfere with this process. Some of them change the way your body handles calcium, the main building material your construction crew depends on. Others disrupt the hormone signals that tell your building crew when and where to work. And some speed up the demolition crew without giving the builders enough time to keep up. The result is always the same. Your body tears down more bone than it builds. At first, you don't feel it. There's no pain, no obvious sign. Your bones look fine from the outside. And your diabetes numbers may look great on paper, but inside, the structure is slowly getting thinner and weaker, the way a wall looks solid until you realize the inside has been hollowed out. This is called bone loss, and the advanced stage of it is called osteoporosis. But here's what matters most for this conversation. The bone loss caused by these medications can happen even in people who eat well, stay active, and take their prescriptions exactly as directed. It is not about doing something wrong. It is about not having information your doctor may never have shared with you. So, before we talk about which medications are involved and what you can do about each one, I want that image to stay with you. A construction site where the demolition crew keeps showing up, but the builders are slowly being sent home. That's what we're dealing with. And that's exactly what I'm going to help you understand and protect yourself against, one medication at a time. Let's get into the first drug. The first medication I want to talk about is called a thiazolidinedione. Most people know this class of drug by one of its most common names, pioglitazone. You may also hear it called Actos. It's been around for decades, and it's prescribed regularly because it does a genuinely good job of helping the body use insulin more effectively. It's not a bad medication, but there is something about it that most patients are never told. When I bring up bone health with patients on pioglitazone, I almost always hear the same response. But my doctor said this was one of the gentler options. And they're not wrong. For blood sugar control, it often is. The problem has nothing to do with how it handles glucose. The problem is what it does to your building crew. Here's what's happening inside your bones. Your body has stem cells. Think of them as workers who haven't been assigned a job yet. Under normal conditions, many of these workers get directed to become osteoblasts, which are the builders we talked about in the last section. But pioglitazone activates a specific receptor in the body called PPARG. When that receptor gets switched on, it changes the assignment. Instead of sending those stem cells to become bone builders, it redirects them to become fat cells, specifically fat cells inside your bone marrow. Your demolition crew is still showing up every day, but your building crew is being quietly reassigned before they ever reach the construction site. The result is a measurable increase in fracture risk, particularly in the hip, the wrist, and the spine. The exact areas where a fracture in someone over 60 can become truly life-changing. And this isn't just a theory. A study published in the Journal of Clinical Endocrinology and Metabolism in 2007 found that women with type 2 diabetes who used TZDs had roughly double the fracture risk compared to those who didn't. It's double. Not a small difference, not a rounding error, but a significant finding that took years to reach most patients. So here's the question I want you to sit with for a moment. Are you currently taking pioglitazone? And have you had a bone density scan in the last 2 years? If the answer is no, that is the gap this section is asking you to close. The daily habit I want you to take from this section is simple but important. At your next doctor's appointment, ask specifically about a DEXA scan. That's the standard test that measures bone density, and it's painless and quick. If you've been on a TZD for more than 12 months, you have a clear reason to ask for one. Don't wait for your doctor to bring it up. In a busy appointment, it may never come up. You have to be the one to ask. That one conversation could tell you everything. The second medication is one that has become incredibly popular over the last decade, and honestly, for good reason. SGLT2 inhibitors, drugs like canagliflozin, dapagliflozin, and empagliflozin, do something quite remarkable. They help the kidneys remove excess sugar from the blood by passing it out through urine. And along the way, research has shown they also protect the heart and kidneys in ways that other diabetes medications don't. For many patients over 60, they feel like a genuine breakthrough. So when I bring up bone risk with patients on these medications, the pushback is immediate. How could something with that many benefits hurt my bones? It's a fair question. And the answer is that the same mechanism making this drug so effective at clearing sugar is also creating a problem deeper inside your skeleton. Here's what's happening. When your kidneys start excreting more glucose, they also begin to shift the way your body handles phosphate, which is one of the key minerals involved in building and maintaining bone. This shift can cause the body to raise its levels of a hormone called FGF23. Think of FGF23 as a signal that tells your body to hold back on absorbing calcium. When FGF23 goes up, calcium absorption goes down. And when your bones aren't getting enough calcium, your demolition crew starts pulling it directly from bone tissue to keep the rest of your body supplied. Your skeleton becomes the backup supply of calcium your body raids when it can't get enough from elsewhere. The consequence is accelerated bone loss and a notably higher risk of fracture, particularly at the hip. This is not a newly discovered concern. In 2015, the FDA issued a specific safety communication, flagging canagliflozin for 2 serious bone-related risks: atypical femur fractures and decreased bone mineral density. That warning came from real patient data, real fractures. And yet, many patients on these medications today have never heard a word about it. So here is the question for this section. Have you started an SGLT2 inhibitor in the last year and noticed any new aching in your lower back or hips? New discomfort in those areas after starting a new medication is worth mentioning to your doctor. Don't file it away as stiffness. Say it out loud at your next visit. The daily habit here is about giving your building crew the raw materials they need to keep working. Aim for at least 200 milligrams of calcium per day, and get as much of that from food as possible. Dairy products, fortified plant milks, and sardines eaten with the bones are all strong sources. Supplements can help fill the gap, but food sources are absorbed more reliably by the body. One more thing, ask your pharmacist whether there is an ideal time to take your medication relative to your biggest calcium-rich meal. Timing matters more than most people realize, and your pharmacist is the right person to ask. The third medication on this list is one that millions of people over 60 depend on every single day. And I want to be careful about how I say this, because I am not here to frighten anyone away from a medication they need. Insulin is essential. For many diabetic patients, it is not optional. It is life-saving. But there is a specific risk that comes with long-term, high-dose insulin use that almost nobody explains, and not knowing about it is genuinely dangerous. When I raise this with patients, the response is usually something like, "Well, I have to take it. I don't have a choice." And that may be completely true. This section is not about stopping your insulin. It is about understanding a chain of events that your medication can set in motion, so you can take one simple step to interrupt it. Here's the mechanism. Insulin, when the dose is not perfectly matched to your food and activity level, can push your blood sugar too low. This is called hypoglycemia, and in its mild form, it might feel like shakiness, lightheadedness, sudden confusion, or weak legs. Most patients over 60 have experienced this at least once. Many experience it regularly and consider it just part of managing their condition. But here is what those episodes are doing to your body beyond the immediate discomfort. When your blood sugar drops, your brain and muscles don't get the fuel they need to function properly. Your reaction time slows, your coordination suffers. Your legs may feel unreliable beneath you. For a younger person with strong, dense bones, a stumble might mean nothing. For someone over 60 whose bones have already been thinned by years of diabetes and medication, a stumble becomes a fracture. The fall risk and the bone loss are not two separate problems. They work together, and the combination is what makes this so serious. Research published in Diabetes Care found that insulin users over 60 had a significantly higher rate of fall-related fractures compared to patients managing their diabetes with oral medications alone. The fractures weren't happening because of the insulin directly. They were happening because low blood sugar episodes were causing falls, and weakened bones were making those falls catastrophic. So here is the question I want you to answer honestly. Have you had more than 2 episodes in the past month where you felt shaky, dizzy, or confused, even briefly, even mildly? If the answer is yes, here is your daily habit. Get a sticky note and put it on your fridge. Every time you feel shaky, dizzy, or suddenly confused, write down the date and what happened. That's it. Just the date and a few words. Bring that note to your next appointment. 3 or more episodes in a month is exactly the kind of information your doctor needs to adjust your dose safely. Have you or someone you love been on any of these medications for more than a year without a bone density conversation? Type bones in the comments. It tells me this information is reaching the people who need it. Now, I want to talk about something that isn't a fourth medication, but in many ways, it makes everything we've already discussed significantly worse. It's a deficiency that is extraordinarily common in adults over 65 with type 2 diabetes, and most people have no idea they have it until they specifically ask to be tested for it. Vitamin D deficiency. Studies consistently show that a large portion of older adults with diabetes are already low in vitamin D before we even factor in their medications. The reasons are straightforward. As we age, our skin becomes less efficient at producing vitamin D from sunlight. Many older adults spend less time outdoors. Certain health conditions common in diabetes, including kidney changes and carrying extra body weight, also reduce the body's ability to activate vitamin D properly. So, for many patients over 60, the starting point is already a deficit. Here is why that matters so much in this conversation. Vitamin D is not just about sunlight and mood. It plays a central role in how your body absorbs and uses calcium. Without enough vitamin D, your intestines cannot pull calcium out of the food you eat efficiently. Your body ends up with less calcium available. And we already know what happens when that occurs. The demolition crew keeps working and the building crew runs out of materials. Now add the 3 medications we've just discussed. Each one, in its own way, already disrupts the calcium and bone-building cycle. TZDs redirect your bone-building stem cells. SGLT2 inhibitors raise FGF23 and reduce calcium absorption. Repeated hypoglycemic episodes from insulin increase fall risk onto already weakened bones. Vitamin D deficiency doesn't create a new problem on top of these. It pours fuel on all 3 of them at once. Think of it this way. If your building crew is already short-staffed and low on supplies, vitamin D deficiency is what cuts off the delivery trucks entirely. Even the bone your body is trying to build in these conditions ends up poorly mineralized. That means it looks like bone, but it isn't as strong as it should be. It's softer, more brittle, more likely to crack under pressure that healthy bone would handle without any problem. This is why I call vitamin D deficiency the accelerant. It doesn't start the fire. Ask for a blood test called a 25-hydroxyvitamin D test. This is the standard way to measure vitamin D levels in the body. When you get your results, don't just accept normal as the final word. Most labs flag deficiency at 20 nanograms per milliliter, but for bone protection in adults over 60, most bone health specialists recommend a target of 40 to 60 nanograms per milliliter. That's a meaningful difference. Know your number and ask what it means for your bones specifically. I want to pause from talking about medications for a moment and talk about something your body may already be trying to tell you. It's a sign that shows up in the most ordinary, unremarkable way, which is exactly why almost every patient I've ever seen has dismissed it completely. Height loss, not dramatic height loss, not something you'd necessarily notice in the mirror from one day to the next. I'm talking about the kind of gradual change that sneaks up on you over years. Your shirts fit a little differently in the torso. A pair of trousers that used to puddle at the floor now sits at the right length. Someone in your family makes a passing comment that you seem a little shorter than you used to be, and you laugh it off. Because of course you do. Everyone gets a little shorter as they get older. It's just age. But here is what I need you to understand. Losing more than 1.5 inches of height over your lifetime is not simply a normal part of aging that can be safely ignored. In many cases, it is a signal that small fractures have already occurred, silently, in the bones of your spine. These are called vertebral compression fractures, and what makes them particularly difficult to catch is that they often happen without any dramatic pain. No sudden fall, no obvious injury. The bone simply compresses under the weight it can no longer support, and the body absorbs it quietly. By the time most patients find out, several of these fractures may have already occurred. In my clinical experience, height loss is one of the earliest physical signs that bone density has dropped to a concerning level, and it is almost certainly the sign that people on diabetes medications are least likely to connect to those medications. They connect it to age, they connect it to posture, they connect it to years of desk work or heavy lifting. What they rarely consider is that the medication managing their blood sugar has been slowly reducing the structural strength of their spine in the background. This is the sign I most wish my patients would take seriously earlier, because by the time it's visible, the process has often been underway for quite some time. The good news is that knowing about it means you can act on it, and acting on it is straightforward. The daily habit for this section costs nothing and takes less than 2 minutes once a year. Measure your height. Not roughly, not by memory, but properly. Shoes off, standing straight with your back against a wall, eyes looking straight ahead. Have another person mark the wall and measure from the floor. Write the number down with the date and keep it somewhere you won't lose it. Do this every year. If you notice a drop of more than 1/2 inch from one year to the next, or more than 1.5 inches from your tallest adult height, bring that information to your doctor and say these words: "I want to talk about my bone health." That measurement, written on a piece of paper, could be the most important number you bring to an appointment this year. Everything we've talked about in this video, the medications, the vitamin D deficiency, the silent height loss, the low blood sugar episodes, all of it is pointing toward one outcome that I need to speak to you about directly. Not to frighten you, but because this is the part that most health videos skip over. And skipping over it is exactly how people end up blindsided. Hip fracture. It is the endpoint that nobody wants to discuss, and the one that most demands your attention right now. Because unlike a fractured wrist or even a spinal compression fracture, a hip fracture in someone over 60 does not just mean surgery and a few weeks of recovery. For many people, it marks the beginning of a rapid and devastating decline that has nothing to do with how healthy or active they were before it happened. Here is the statistic I want you to hold on to. Research published in the Journal of Bone and Joint Surgery found that adults over 60 who sustain a hip fracture have a 20 to 30% chance of dying within the following year. 1 in 4 to 1 in 3 people, and in almost every case, it is not the fracture itself that causes death. It is everything that comes after, the immobility that leads to blood clots, the extended bed rest that leads to pneumonia, the sudden loss of independence that triggers a rapid physical and mental decline that the body, at that age, simply cannot reverse. I have seen this happen to patients who were walking, driving, and living fully independent lives just weeks before a fall. Strong people, careful people, people who were doing everything right for their diabetes. The fracture was not the end of a long illness. It was a single event, one bad step, one moment of dizziness from a low blood sugar episode that changed everything. This is why the bone risk tied to these medications is not a minor footnote. Effect that only happens to other people. It is a documented, measurable, specific danger that grows with every year these medications are taken without monitoring. So here is the one action this entire video is built around. If you are currently taking pioglitazone, an SGLT2 inhibitor, or long-term insulin, and you have not had a bone density scan, called a DEXA scan, in the last 2 years, I'm asking you to call your doctor's office tomorrow. Not next week. Tomorrow. I want to be clear about what you are asking for. You are not calling to change your medication. Your doctor manages that, and that conversation happens in its own time. You are calling to request a DEXA scan and to say that you want to have a bone health conversation at your next visit. Those are two separate things, and you have every right to ask for both. One phone call, tomorrow. That is all this section is asking of you. We've covered 3 of the most commonly prescribed diabetes medications and the specific ways each one can compromise bone health after 65, along with one practical habit for each. And before I close, I want to be honest with you about something. Every patient I've described in this video was doing everything right. They were taking their medication as prescribed. They were showing up to their appointments. They were checking their blood sugar, watching their diet, staying as active as they could. By every standard measure, they were model patients, compliant, consistent, informed, and still, their bones were losing density year after year, quietly and without warning, because nobody had ever sat down and connected these two things for them. That is not a failure of the patient. That is a failure of information. Routine appointments are short. Doctors are stretched. And bone health, when your diabetes numbers look good, rarely rises to the top of the conversation. It gets pushed to next time, and next time becomes next year. And next year becomes a fractured hip in a parking lot on an ordinary Tuesday afternoon. I don't say that to make you angry at your doctor. I say it because understanding why this information gap exists is what helps you close it yourself. You now have something most patients don't have walking into that appointment. You have the specific questions to ask and the specific test to request. That changes everything. So here is the simplest action I want you to take tonight. Not tomorrow, tonight. Find your medication list. It might be on your phone, on a piece of paper in your wallet, or on the counter next to your pill organizer. Look at it. If you see pioglitazone, any SGLT2 inhibitor, or insulin on that list, write 4 words somewhere you will see them before your next appointment. DEXA scan, bone conversation. That's it. 30 seconds of your evening. 4 words that could genuinely change the trajectory of the next decade of your life. If anything in this video resonated with you, if something I said made you think of a parent, a sibling, a friend, a neighbor who is managing diabetes and has never heard any of this, please share this video with them. Put it on their screen. Tag them in the comments. You may be giving them something their last doctor's visit simply didn't, and that is not a small thing. That is the kind of information that protects people. If you want to keep receiving medical information that treats you like the intelligent adult you are, no scare tactics, no vague warnings, no oversimplification. Subscribe to this channel. Every video I make is built around one goal, giving you the specific, honest, usable information you need to take better care of yourself and the people you love. Thank you for watching all the way to the end. That tells me you're exactly the kind of person who takes their health seriously, and that matters.